Not yet.
Okay.
Right after this announcement.
The broadcast is now starting. All attendees are in listen-only mode.
Okay, everybody. This is Joan Mizell, and I appreciate everybody that's on the line tuning in on a late Friday afternoon. So I will try to ease your way into the weekend by not presenting anything that's too difficult to comprehend. What I'm going to do is to talk about where I stand in developing this evaluation master plan for the OAC. And I want everybody to understand that what you're going to hear today is a draft, that this information has been presented to the evaluation committee of the OAC and is being reviewed kind of on an ongoing basis by the staff of the OAC, but the commissioners have not yet seen the information, certainly have not yet approved what's in this plan, and so I would just urge everybody to be cautious if, in fact, you wind up talking about it to anybody, that you make sure that you have people understand that it's a draft at this point and not by any means an official OAC document. Okay, what I'd like to talk about is sort of outline the master plan for you as it stands now. And that involves talking a little bit about the background and the process I've used so far, basic evaluation questions and the scope of the master plan, a little bit about priority setting, and then most of the detail, and we won't go through all of it, is actual evaluation activities at the person and system level, the community level, and then some discussion about some of the individual MHSA components and how they sort of fit into the overall evaluation plan. And then there's one final slide that talks about data systems, since that's obviously a critical issue for all of this. You heard this morning, I think most of you, about the role and prior work of the OAC in evaluation. Essentially, as you could tell, there's been a lot of evaluation activity or evaluation-like activity that the OAC has done. But once the initial big UCLA contract was sort of nearing its completion, and as some of the individual evaluation activities were getting underway, it sort of became clear to the commissioners that they didn't have a kind of overall sense of where they were going in terms of evaluation. And so last year, the evaluation committee itself, I believe, and the commission said that they would like to have kind of a plan for what they would do in evaluation over the next 3 to 5 years. And so that's essentially what this plan is and what they hired me to put together. The process I've gone through is I interviewed a whole bunch of folks, 30, 40 people, did site visits to 4 counties to find out what they're doing in the way of evaluation, done some review of what is happening in other states and what's happening nationally in terms of evaluation and behavioral health. And there have been a couple of reviews of progress as I've proceeded with the evaluation committee of the OAC. And I think, as Renee mentioned this morning, the draft of this plan is due to the commission by the end of this calendar year. Want to try and set expectations for this plan, both in terms of what it is and as importantly, what it isn't. The master plan is being developed specifically for the OAC. It's not intended to be an evaluation plan that answers everybody's questions or meets everybody's needs or incorporates everything at every level. It's specifically a plan of action for the OAC for the next 3 to 5 years. While most of the plan relates specifically to the MHSA, I think, as we all recognize, it's virtually impossible in some regards to evaluate the MHSA by itself, particularly as the MHSA has had an impact on the system of care in general. It's hard to isolate the impact of the MHSA, and as you see when we get into more of the details, particularly around the performance monitoring scheme, we're really looking at the functioning of the state's public mental health system as opposed to just the MHSA. And there are considerations for some of the specific MHSA components, but that are addressed later on in the discussion here. But the basic idea is that this evaluation master plan, or the scope or scheme of the thing, is that it will be as integrated as possible and not component specific. There are certain things that are component specific, but the overall thrust is to have this evaluation plan look at the MHSA as an integrated whole. And as I said, this includes a list of activities. I think there's more than enough activities listed here to fill a 3 to 5 year evaluation agenda. How quickly these activities get
Joan, we've lost you. and over time represent an evaluation of the whole scheme. I think it's also important that results, or they think it's important, and I agree, that the results that are produced through these evaluations be easily understood and interpreted by non-technical people. We want things to be technically accurate, but we also want them to be meaningful to non-technical people. Okay, the basic model and scope, and I do something like this only to kind of set a context. I think we sometimes get a little too involved in our frameworks and our schemas and our models, and really what I've tried to emphasize or will put into this plan is really a set of concrete things that the OAC can do, and trying not to get too bogged down in discussions about frameworks and models. But I do think it's important to have some kind of sense of the overall scheme, for the lack of a better term. And my brain works simply sometimes, and in this case I think the basic evaluation questions are a set of questions about the inputs and then a set of questions about the outcomes. And the inputs are, the planning process, the money, and a whole bunch of other things that have happened during the course of the last 5 or 6 years. The outcomes are outcomes in the mental health system. The basic question is, has the mental health service system improved? And then has the mental health system infrastructure improved, since there were clearly MHSA dollars devoted to infrastructure. And then as a result of those system changes, are the people who are receiving services doing better? And then in the community, are outcomes better, including outcomes for people not directly served, and have stigma and discrimination been reduced? So those are the basic evaluation questions. And this next one is way too detailed to talk much about, but it lists the kinds of elements that are involved in trying to address those basic evaluation questions, which are now at the bottom of the slide. And for example, with mental health system outcomes, where we say, has the mental health system changed, we're clearly interested in the changes that are promoted by MHSA, recovery orientation, integrated service experience, etc. And then the impact of those changes on people receiving services in these major outcome areas. And then the community level impacts we'll talk about a little bit later, since people have got a different kind of sense about what that might mean. But you can see that this retains the original notion that Stephanie Operndeck started this out with person level, system level, and community level. And as I understand, your work group that's the presentation here is for, is raised the question about program outcomes. And that kind of conversation can go around in circles, but my sense is that as I use the terms, the program sort of fits in the system outcomes. So mental health program or system outcomes. All of these outcomes in the system box are equally relevant to programs, and you can think about summing up the impact of the programs as well as the infrastructure into what constitutes the mental health system. Okay. This next part is important because it's what I've used basically to organize the information in the plan. I think there's been, or always is, confusion about what we mean exactly by evaluation methods. But I think what I've tried to do is talk about three basic methods. This is evaluation loosely understood. For those of you out there who are serious evaluation people, which I think most of you are, you'll note that 2 out of the 3 aren't really evaluation. They're evaluation-like methods, but I think it's a way of maybe helping people to understand what it is that we're doing. At least I hope so. So I've got 3 suggested methods: monitoring of performance indicators, evaluation studies, which is what we're mostly used to when we think about evaluation, and then something I've called developmental and exploratory work. I'll just mention these, go over these a little bit. I think, again, with this audience, you understand what these terms mean, but the performance monitoring with performance indicators basically measures a characteristic of a population or system, usually measured at a point in time or over a set period of time. It can be used to compare across entities or over time. Again, it's not strictly evaluation, but it's a way of sort of tracking performance, again, over time or across entities. And you can see some of the examples listed there. And the basic uses of this kind of, performance monitoring and performance indicators has become a big thing in not only behavioral health, but healthcare in general.
both for the purposes of quality improvement, but also for the purposes of compliance or the purposes of comparing entities. The uses, I think, in this context are to look at what the data tells us in terms of raising questions or concerns. It can be motivational if comparisons are used or benchmarks are set. And it can lead to identification of practices of good performers. The second method are evaluation studies. This is what, again, we generally mean by evaluation, a lot of us technical folks. You're basically measuring the results of a particular effort or intervention. It can be a program, it can be a process, it can be an initiative that you're measuring the effectiveness or efficiency of. The better specified the intervention, the more useful the evaluation will be. It can be narrow or broad. And the methodologies obviously vary in rigor. And our reliance on evidence-based practices basically comes from those evidence-based practices having been submitted to rigorous evaluation studies. And the basic study then is, does participation in a particular program or program type result in improved outcomes? And then there's an example here about an evaluation potentially of Tier 1 centers. Okay, the third method I'd call developmental and exploratory work. And some of the studies that Renee talked about this morning and some of the things that the evaluation committee of the OAC has talked about in the past really are seen as more capacity building or developmental, or not really. It's kind of work that needs to be done before we can really address a serious, rigorous evaluation question. It's something that will help us understand the system, understand outcomes, figure out what the right outcomes might be. And I've given some examples here of the kinds of things that I have in mind, like how can we track outcomes for persons in less intensive services than FSPs? How can we assess the recovery orientation of programs? Is it possible, feasible to risk adjust FSP clients? The kinds of things that are really preliminary to then using that information to do more rigorous evaluation. Okay, quick word about priority setting. I've suggested some criteria for the setting priorities for the evaluation questions, and then some criteria for evaluating the characteristics of an evaluation project. And these criteria can be applied to the evaluation activities that are listed in the plan, and more importantly, can be used by the OAC starting right away to reevaluate if they want. My take on the high priority items, and even more importantly, after the first year, if they want to reset priorities in terms of these criteria or other criteria that they want to add. My sense of using criteria is that it's very subjective. That it's hard to come up with something that everybody's going to agree to, but a system like this where you just do high, medium, low, fitting each one of these criteria will usually give you a pretty good sense of consensus about what priority items ought to be. Okay, so now to a little bit more of the meat of the plan. This section here talks about person and system level priorities. And I'll go through then the 3 evaluation methods as they refer to the person and the system level. So the first one is performance monitoring.
And the goal is to get a set of indicators that has high reliability and relevance. The populations covered, and this follows along from the work that Renee talked about this morning, the priority indicator report that UCLA is just completed. And there's information in there on everybody served, which comes from the CSI and the samples from the Consumer Perception Survey, and some of the analyses and indicators are just for FSPs. And all the indicators now and in the future should be broken down wherever possible by demographic characteristics and county. The suggestion is that the performance monitoring system obviously continue, and that after the conclusion of the UCLA contract, that DHCS take over the ongoing responsibility of producing the data to the specifications of the OAC, that the OAC staff then has the responsibility to interpret the data results, not to do heavy-duty analysis. They will ask DHCS to give them the tables, for example, that they want, but that interpreting the data and drawing implications from it is something that we haven't really done yet, and which is absolutely critical. I mean, sometimes we have more data than we can use. I mean, it's not a shortage of data, it's a shortage of the capacity or willingness or time to actually look at the data, interpret what it means, ask some questions, draw implications, and so that's going to be the fundamental responsibility of the OAC staff. And then the OAC has the responsibility to disseminate that information widely in formats that are understandable by stakeholders. Again, that's something that the OAC and, to my way of thinking, a lot of other folks have not done as well as could be. Okay, so the highest priority in the area of performance monitoring is to refine the existing priority indicators. And I think, as some of you noted this morning in Renee's presentation, and if you read the full report, you'll see that there really are some serious problems with data completeness, with which data elements were used for each of the indicators. They're not devastating problems, but they're the kinds of things that you would expect to find when you first actually get into the data and try to do this. And so the highest priority in this area then is for work to continue on refining those priority indicators and eliminating those that we decide we can't get reliably or that aren't useful, that we can't make anything of. Then the next highest priority is to pilot and then add some additional indicators. And I've listed some here that I have a list there'll be a list in the report of a dozen or more, probably about a dozen of these. And some of them relate to indicators that are becoming more prevalent as the behavioral health world gets more integrated into the healthcare system. Some of them relate to indicators that the National Committee on Quality Assurance is suggesting. The trick here is going to be to pick a couple and not get overwhelmed and pick too many, but to pick a couple that people think are most important and to pilot them. In other words, gather data from a couple of counties and see how good the data is and see whether it's something that we want to do on a more ongoing basis. Okay, then the second kind of study in this person and system level, the high priority evaluation studies that are suggested is at the person level that the OAC collect, summarize, and publicize outcome data from counties that are gathering such information. Counties are doing a good job in some instances of collecting this kind of information. The OAC can perform the function of gathering that information together and putting it out in a format that people can understand. And then I think that a study should be done to measure change over time, which is not part of what happens with performance indicators, but measure change over time on the same clients on some standardized outcomes in DCR. This is what some counties are already doing. I think the state could try to do it, and I think they should try to do it for more than just the first 12 months, for a 24-month period. At the system level, some high-priority evaluation studies determine the effectiveness of peer-run services, selected early intervention and selected prevention programs. It's something that the OAC is already starting this year, and the recommendation here is they continue and expand upon that. And then there's two other suggested studies, one for TAE clients and one for older adults. Medium priority evaluation studies. At the person level, determining outcomes of promising or community-based practices, particularly with regard to underserved and inappropriately served populations. Then at the system level, two potential studies on that relate more to integration of services, screening all people at what's the extent, effectiveness, and challenges of screening people for substance abuse, and some counties are already doing that. It shouldn't be too hard to get some counties to be willing to participate in the study. The same questions about obtaining routine physical health status on all clients and FSPs. And then a suggestion that the recent FSP cost offset study that the OAC did be repeated again, and calculate the offsets not just for the free in the first 12 months, but 12 to 24 months of enrollment. Okay, then in the third evaluation method for person and system level, the kinds of high priority items suggested are developing a system for tracking performance of persons receiving less than the most intensive FSP services. There's a lot of variation, obviously, in terms of what FSP services are now, but still I think most continue to be quite intensive, at least with adults. And there's been movement towards FSP Light, or a second level of care for counties that are using levels of care. And Los Angeles, for example, has been putting in place a system for tracking performance of people in their second level of care. And a developmental piece of work would be to work with folks and figure out how programs could be defined, and then figure out what kind of outcomes would be most important for those kinds of programs. At the system level, this first one you also heard a little bit about this morning, about determining the status of county evaluation efforts, both in innovation, where they're required to evaluate a project, as well as in PEI projects, where the guidelines required counties to evaluate at least one PEI project. Some interest in high priority developmentally is exploring the feasibility of classifying FSP programs. There's great reluctance to compare outcomes since we're comparing apples and oranges, and it probably would be useful to see if we could figure out a way to classify FSP programs. And then another high priority item, exploring the extent and variation in the recovery orientation of programs. We have so much emphasis on recovery. It's been one of the major impacts, I think, of MHSA, and there are mechanisms out there and scales out there to measure the recovery orientation of programs, and I'm suggesting that a high priority would be to put some energy into finding out more about that. And then finally, some medium priority items in the developmental exploratory work interaction between the characteristics of the population served in FSPs and outcomes. There's been interest over time in seeing if we can come up with a risk adjustment which would allow for more meaningful comparisons of program outcomes. In terms of PEI, the current work that Renee talked about this morning is going to try to do some classification of early intervention programs. And this is an effort to build upon that and see if there's a way to describe and catalog all the programs funded by PEI. It's not a simple task. And then this piloting of an immediate consumer feedback method. People are talking about how important that kind of system might be. It doesn't fit into necessarily something that's of statewide impact, but it, from an exploratory perspective, it might be something that would be of interest to programs and something that the OSC could fund. Okay, a couple of words about community level outcomes. In my conception here, this level covers outcomes for populations, including those who have not been served by the public mental health system. Why do we include this, besides the fact that it was in the original conception? Well, I think the reasons are important. The goals of the MHSA actually extend beyond just improved services. They really are, the values and goals extend towards the whole society, actually, and not just MHSA services. There's a recognition from some of the leaders in the state that the public mental health system can't do it all, and that we need to be paying more attention to community supports, which wouldn't be reflected just in the mental health system. It's a critical way to monitor the overall success of reducing disparities. And this is the same kind of population approach that consistent with what RAND folks did with their PEI framework. To get community level outcomes, you have to define a population, and then you measure an attribute of that population. And the suggestion here is that there's 3 types of populations that are of interest: everybody in a community, those in the community with serious mental health issue, and those in the community at high risk. And the major way you assess things is through surveys, because the idea is to survey not just the people receiving services, but either survey everybody in the community or everybody with a serious mental health issue, which you can get from one of these surveys as well. Performance monitoring is the major evaluation method that you would use for assessing community level outcomes. And the goal is to establish a set of indicators that can be tracked over time. And RAND has done a good job of identifying possible data sources for gathering this information on a community basis, but more work is needed to specify the specific data elements that would be needed and to establish a tracking system. And here's some examples of the kinds of things that you would track. The only way to measure the prevalence of mental illness and whether all of this MHSA activity has had an impact on that is to survey everybody in the community. We can get penetration rates by surveying everybody, picking that subset of people who have mental health problems, and seeing the extent to which they've received some kind of service or support. And as you know, Renee noted this morning, and as we all know, that you know, less than half of the folks who have mental health problems wind up getting a service. One way to track whether that changes or not is by using these surveys to measure these some of these indicators. Okay, then there are some specific issues that are related to the specific components of the MHSA. And let's talk first about prevention and early intervention. The prior and current work of the OAC, Renee already talked about this morning. I want to mention the RAND major multi-year evaluation of 3 of the statewide initiatives that they're doing for Cal Mesa. I mean, that's a major undertaking and a major investment of resources in evaluation. Then there's the statewide evaluation framework that RAND developed, which takes a population-based approach and, like I said, compiled a whole set of potentially relevant data sources. Then I think we should keep in mind the California Reducing Disparities Project, which is one of the 4 statewide PEI projects, I'm sure you all know, and there have been 5 strategic planning work groups that compiled a list of community-defined evidence and population-specific strategies, and these are being combined into one plan, which will then lead, as I understand, to a set of RFPs for programs. Now, the challenge for evaluating PEI is to remain faithful to the MHSA intention of integrating PEI activities into a seamless mental health system. In other words, we want to consider PEI as part of the continuum that goes from, you know, selective prevention to early intervention to treatment programs. And so the basic results or outcomes, for example, with the performance monitoring, are going to be the same for PEI as they are for treatment programs. It's all basically one continuum, and we don't want to forget that. But on the other hand, you know, this is a pretty unique opportunity when a state devotes the kind of money that's being devoted here to prevention and early intervention activities. And we want to do enough evaluation of the specific PEI activity so that we can, you know, show basically what's happened, as well as answer some of the more recent criticisms. Okay, so a high priority for PEI evaluation is the first one we've talked about before, is to review the status of the county's evaluation efforts to evaluate one project and try to get those kind of up to speed, because that's where a lot of the critical information about the effectiveness of these PEI projects is going to come from. Continue the strategy of evaluating clusters of common programs. That's, Renee talked about that today. And then the third one I'm hoping people will pay more attention to is that these California Reducing Disparity Project effort should include evaluation of the activities that are going to be conducted under the project. Rather than having some outside source like the OAC or an OAC contractor do an evaluation of those projects, it seems to me that strategic planning groups, work groups that have developed the plans are in a perfect position to require whoever gets these contracts to include a portion of their funds evaluating the successfulness of the projects. So I think that's a high priority. Medium priority, taking advantage of the county efforts. Again, some counties are really making pretty significant efforts at evaluating their PEI projects. And then we talked about developing an ongoing method for describing and cataloging the programs. Okay, innovation is also a unique kind of situation here that, you know, the ultimate purpose of the evaluation is not just determining whether a particular innovation program is successful or not. The real evaluation is this a good strategy for introducing improvements in practices to fund innovation projects, have them evaluated, and having the results of those disseminated. So this is really a multi-year endeavor which looks not just at the successfulness of the innovation projects, but the successfulness of the strategy in terms of whether those innovation efforts that are shown to be successful are then disseminated. So a high priority is first to see whether the counties are in fact doing what they're supposed to be doing in terms of evaluating, or whether they, you know, setting up evaluations of the projects, or whether they need some more assistance in making sure that those evaluation efforts are adequate. Then the medium priority is once that, and it's medium only because it's going to take a while to get to it, not that it isn't of equal importance, but to see how well the dissemination activity of those successful innovation projects is being done across the state. Okay, just a few more slides here. Technological needs. Current activity is that the EQRO reviews annually the status of county information and technology projects, and the basic evaluation effort, as I see it, regards this component is to track and document what the money has been spent on and how the projects have affected the county's information technology capacity and how that capacity can improve overall service delivery. My visits to counties suggested to me that one of the major impacts of MHSA may be to have spurred the evolution of the capacity of counties to develop new information technology. There's really a lot of activity going on, and I think we want to get a better understanding of what that is and how it's potentially improving service delivery at some point down the line. So the high priority is to develop and implement a plan for routine monitoring and special studies of the impact of the technology expenditures. OAC can't do this alone, actually. A lot of things we talked about would be better done, obviously, in collaboration with others, but this one in particular really requires IT expertise and program expertise, and need to develop a plan for how to track what it is that's going on in terms of technology. And, a separate section, there was special mention in the Act about county efforts devoted to family empowerment projects in terms of IT, and I'm not sure anybody's taken a look at that yet, so that should be part of the plan. And then the priorities for how to for the plan implementation can be decided once the plan is developed. And one idea that we've had and talked about is using the EQRO to maybe do some more of this work, since they're already going out to counties. Maybe if there's a format developed that would indicate what information we want about how MHSA funds have supported IT activity, they could gather some of this information on their regular visits. Okay, in terms of WET, we know that the main responsibility for that has been transferred to OSHPD. And so that the OAC's role here is really to maintain overall oversight of the component. So the Commission needs to just be in touch with and review the results of what OSHPD does in terms of evaluating its efforts. And there is a new 5-year plan that I think is due soon, and presumably OSHPD will include some evaluation information based on what's happened with the original plan. And the last one, capital facilities. Capital facilities basically is just tracking what projects have been implemented and what to do with regard to housing. I'm still working on. Okay, so then there's just one overarching issue that I want to raise, get my 2 cents in here, particularly as it relates to the work you folks are doing in terms of a business plan for DHCS. You folks have already noted, as everybody else has, that there are serious problems with what it is we have in place now. Besides it's being antiquated, it just hasn't been supported in recent years by DMH. It's unclear, at least to me, how the existing data sources fit into any overall IT plans that DHCS has. The current situation is also characterized by what I said before. The counties are engaged in significant IT upgrades. There's obviously a desire for a new data system architecture. So my 2 cents about this is that the highest priority is to urge DHCS to provide sufficient support for the existing data sources. Even if we were to launch a new effort tomorrow, it would be quite a while before we had a new data system. That's not the case, obviously, for counties. Counties can get there much faster on an individual basis. It still takes time, but they can get there faster. But trying to do this on a statewide basis is going to take time. So unless we want to just tell the public to hold on and we'll get back to them in 3 or 4 years, DHCS has got to be urged to provide sufficient support for the existing data sources. And then I think with others, the OAC should work with knowledgeable state and county PICS IT evaluation and program people. I think not necessarily to design a new system. I think the first step is to determine the feasibility costs and what timeline for the development of the new statewide data architecture. And after that's done, then see what is possible to do. Okay, that's it. Questions, comments, whatever.
You can ask. Oh, there's one. Sweet. Wayne, can you speak loudly, please?
Yes, actually, I was just testing to see where I could raise my hand or not, so evidently my test worked. Thank you, John. This is very informative. The one question I have is the confidence that Renee had in the previous studies and the, let's see, woeful lack of, not confidence, but lack of completeness of the studies that you've seen in your review of the evaluation of MHSA.
Well, a lot of the studies that, or some of the studies that Renee reviewed this morning were done early on. The ones that were looking at the effectiveness of CSS and PEI, the findings that she reported appropriately with caution in some cases were based on small samples because things were just getting started. And so it's not surprising that counties didn't have a lot of outcome data. I think the cost offset study is a good study. I mean, I think the information is very useful. I think counties had a chance to review some of the data. I think it's I think the methodology, as far as I could review it, is, seems appropriate. The performance indicators, some of the indicators are very good and are useful. I think some of the other ones need work. But again, I think Carol Hood is fond of saying we've been trying to do this for 20 years, and we sort of take a first step and then we throw up our hands in despair. I think this time we have a real chance to keep going and refine the indicators that we're already using, and maybe get some other ones. It's a complicated task, but again, it's made more difficult because because the data systems, it's not just that the data systems are not adequate, it's that they haven't been maintained. But I think we can do better. And so I'm reasonably optimistic that we can get, for the performance indicators, that we can get good enough data that we can start to do some analysis that will lead us to some implications about what all the data means.
So the second question is, so you're very in agreement that the kind of investment that's needed in order to do this is not insignificant. It's actually a significant investment in getting our arms around a long-term ability to measure and keep track of indicators and evaluate our programs.
Well, again, we need to make a distinction between the indicators and the evaluation method. I think it's important to make that distinction. I think we're started on the performance indicators, and that with not an insignificant investment, but a reasonable investment, particularly if DHCS helps out with supporting the data sources better, and particularly with the work of SAC State. With the DCR, I think we can make some progress on the performance indicators. In terms of evaluating individual programs and the evaluation studies, you can do as much of that as you have the money for. And you can do that without big changes in the data system. I mean, you're basically looking at clusters of programs, or you're looking at individual efforts, recovery orientation, or you're looking at individual things that, if you get willing counties and willing programs, you can collect separate data. You don't need to use a big fancy statewide data system to do those kinds of evaluation studies. So I separate the two things, what's needed to do the performance indicators over time, and then what can be done with evaluation studies. I hope that addresses it.
Yeah. One last thing is and I might have missed it, but did you tie anything to the potential for federal reimbursement based on mental health or alcohol and drug outcomes due to treatment? Did you look at that at all?
No. You mean in terms of pay for performance kinds of criteria?
Right.
No. I guess, that's clearly coming. It's obvious that programs need to be thinking about that and thinking about how they're going to incorporate that. But to me, that's not a state level issue at this point.
Okay.
Yeah.
Great. Thank you.
So are there any other questions from anyone else? They can indicate that they want to ask the question by raising their hand. Joan, I think that's it.
Okay. Thank you, everybody. Have a good weekend.
Thank you.
Okay.
Bye.